everyone, I'm Olga TISHKINA, co-founder of New ICEBERG Dental Clinics. We are dedicated professionals who are truly passionate about clinical excellence. Our vision is to resolve even the most complex cases by natural aesthetics with long-term functional reliability. With state-of-the-art infrastructure, an in-house digital lab, and robust quality control protocols, we manage 3,000 appointments every month while maintaining very low complication rate. We are able to manage complex emergency trauma under general anesthesia and treat infants from their very first month of life. Trust is our foundation. 80% of our patients are referrals, and every 10th patient is sent by us by a colleague. Today, our clinical reach extends far beyond our city, serving patients from 60 cities and 8 countries. We are committed to elevating the field through multiple initiatives: lecturing, hosting congresses, and a professional skills championship, to offering 24/7 expert guidance via our trauma hotline. By integrating AI technology and working hand in hand with the IADT, we can save more smiles globally. Thank you very much. Thank you, Nitesh, for having me here. I really like your advanced and warm audience, so thank you so much. I'm really glad to be here. Today, I'm gonna speak about this topic where we can lose teeth not at the site of the accident, but afterwards, due to restorative failures, due to extraction, and so on. I am restorative adult dentist, but because of dental trauma, I became pedodontist somehow. And today I want to share some experience in this crown root fractures. I will show you some techniques that we now consider optimal, and I will share also some complications for each technique. So let's begin. I have a lot to say, so thank you very much. So let's begin. I think we all saw these clinical cases, and usually when we see those patients, we start to feel that we have some bad news for parents. Sometimes those cases can be unsalvageable, and there we can see our pathology at the classification. Incidence rate, prevalence is around 5% of all dental trauma injuries. And if we look into the guidance, IDT guidelines, we see that we have some treatment options. Nevertheless, in our national protocols in Russia, we have shorter clinical recommendations, which says we extract those teeth. So in our clinic, of course, we have to work as according IDT guidance. So we try to avoid these situations. Currently, many teeth are extracted in our country because of these outdated protocols. So this is our status quo. We are working on it. We are trying to change it somehow. But sometimes when we, with the IDT guidance, at the heat of the moment, we try, general dentists and pedodontists also, who used to work with deciduous teeth, feel a little bit confused with all they see. And so we are trying to develop clear decision-making tree. So let's go to definitions. This crown root fracture is the fracture that involves enamel, dentin, and cementum of the root. So it extends onto the root surface. It can be either complicated or not complicated. And when when it comes to restoration and treatment planning, we all know that adhesive technique and all the restoratives are about isolation. We have to have a dry field with no contamination. But in these crown root fractures, we have a big problem. We don't see the whole surface of the root of the. We don't see the whole surface of the fracture, so we can't bond it predictably. And we see, I think, two groups of crown root fractures. One group when the fracture extends up to, well, nearby cemento enamel junction. And the other group which continues deeply below the bone crest. In both cases, we are ended up under the STA, I mean under supracrestal tissue attachment. Under, it's an old term, but we are going under the junction, violating biological width. So these bacterial loads, this bacterial load goes into the, well, bone level, let's say. So under the junctional epithelium, we have continuous bacterial load. So why is this border so sacred? It acts like a natural barrier, so it's like a protective seal between that protects from bacteria from our mouth cavity, oral cavity, to the underlying periodontial. So all our treatment options, the core principle which are lying under those treatment approaches, is the re-establishment of the epithelial attachment along the entire circumference. So we have to make this epithelium seal continuous again, therefore effectively separating oral cavity from underlying bone. The first group of techniques is aimed at preserving the volume of alveolar bone at the anterior region and includes, for example, autotransplantation and another biologically driven approaches. I will concentrate on the third technique, intentional replantation, today, but also will tell about our workflow. So, as to first aid, removing, what is the first aid? The aim is to make patient more comfortable actually after this trauma, because consultation is a little bit tricky, a little bit complex. We have to tell the patient about all these treatment options, about the price, for example, and everything else. So as a first aid, we are not, we won't recommend to take the fragment out, because removing the fragment results in a sudden aesthetic setback and an urgent dilemma for the patient. So therefore, if the fragment is whole, we recommend to keep it in place just for now. It is better to immobilize it without any extirpation of the pulp, just immobilize it like it is. We can fix it, we can fix both fragments together. Try not to apply any adhesive between those fragments. Just stick it together with a button, with an adhesive button, something like this, or maybe just to seal everything all together, so the patient can bite properly, he can eat properly, and he feels just so comfortable afterwards, so he can hear about your consultation afterwards. If we have fragment like this and we don't see the border, we are splinting these two adjacent teeth, like this. So also a patient feels comfortable. And also if we have cracks like this, we can use this rigid splinting. It's wire composite splinting. We also make some alginate impression or scanning, just to get back, like to make a backup of the form and position of the tooth for future restoration planning. The first treatment option we consider when we see those patients is fragment reattachment. It's really simple. It usually takes only one appointment. It's a little bit cheaper than everything else, but we use this technique only when the fragment is just below the cement enamel junction. Something like this, when it doesn't extend very much low below the alveolar crest. That means we can use two types of techniques. First is fragment reattachment with crown lengthening. I mean that we use osteotomy to regain this width, like 2.5 millimeters for biological width. So we move our epithelium junction complex a little bit more apically than our restoration, than the fracture line, I mean. So in this particular case, we see that we raise the flap. Afterwards, we make osteotomy and fix the fragment after the restoration, and checking all the composite residue. We just suture the flap back and prescribe some infection control measures like hygiene, chlorhexidine gel. And here we made it with partial pulpotomy, and we see those results. I'll just show a really short part of this operation, where we use osteotomy. So we reduce the bone to preserve the space for new junction just above our fracture line. We use this method only when we have really good fragments to fix. Like here, we had the whole fragment with uncomplicated crown root fracture, and we fix it as usual. We attach it as usual. We just bond it. Here we check, we double check, or we triple check all the composite residue. We try to make it as precise as possible. We polish it thoroughly before suturing the flap back. Well, if we deal with our national protocols for crown root fracture, that means we all do this as an experiment, actually. So we try to find those parents who agree with this experiment, let's say, who are quite ready to follow all the recommendations as hygiene and all the stuff, and possible loss of this tooth. And here you can see we of course do probing after like 2 weeks after the restoration, just to check the new epithelium attachment. This is the burr that we use for osteotomy. And I think the main disadvantage of this technique is the bonding, because we don't have much enamel left. And even if we make the approximation of the fragments very precise, still we don't have a lot good bonding strength. So sometimes we have debonding and restorative failure. The other disadvantage is that sometimes the root has some more fractures that we don't see. Like in this case, in 3 years after the fixation, we did also osteotomy and fragment reattachment. We had our favorite night call, which said that child is in pain. That's the moment no doctor can sleep this night to see the patient back the morning after. We were thinking that we didn't made a new reattachment. We thought maybe some composite residue did prevent it from healing this reattachment. So continuous bacterial load made all this thing not biocompatible. But when we took the tooth out, we saw that there really was a composite residue, which was the problem. But we also found out that there was some free fragment moving inside. And also we had a crack which was working, I think, like a gateway for a continuous bacterial load. So we had this big lesion and we lost a lot of bone. Sometimes we have things like this. We try to make orthodontic extrusion, and we find in such cases, and we can find out that there is one more root fracture, like combination. We find sometimes cracks inside, very strange ones, which can make also a failure, like this. We made fragment reattachments of 2 incisors. They were quite stable for a year, but then we found out pocketing and find another free fragment. So the real danger that we do not see those additional cracks, additional fractures on the X-rays. They extend in somewhere below the bone level and can compromise the entire treatment by making continuous reattachment that we want, continuous epithelium junction, impossible to achieve. And here, the other case. Yes, we see this crack, but still we made this fixation and made this problem. So we sometimes lose a lot of bone, and that's a really, really big problem. We must be reattaching the fragment in such situation. We should be very, very careful with our prognosis, because the majority of complications are caused by fragments that they are apical to the alveolar crest. We cannot see them on CBCT and other films, so they hinder formation of a proper seal, leading to chronic inflammation. So recently we consider this technique a little bit more frequently. When we just take the fragment out, we let it heal naturally with desmosome to the sound dentin, and afterwards we do shorter restoration from this new level of junction. So we go like step by step. First we check the junction, and we got when we got this border sealed, when we probe everywhere and everything is sealed, we make the restoration shorter from this new epithelium junction level. So maybe that could help. Like this. So we shorten the fragment and do like more safer restoration, let's say. Some advantages and disadvantages of this treatment strategy you can see on the slide. So loss of retention, periodontal pocket formation, vertical bone loss are the most unfavorable ones. So you can see some complications here. I won't be reading this. And we are going to another technique that we consider in more profound fractures. Oh, okay. So intentional replantation is what we use for now much more frequently, because it's the possibility for us to check the whole surface of the root. So it makes a little bit more predictable our prognosis afterwards. We are using those techniques in the cases where the extent of the whole fracture lies beneath the alveolar crest, like here. Also, it's more like, it looks like crown root fracture with root fracture, like T-shaped. Let's see some, let's see some clinical cases. You see Yaroslav? That's the clinical situation inside. We didn't even try to fix the fragment because we didn't have the larger one. So first of all, before starting replantation, we performed endodontical treatment. If we can manage good isolation, we are trying to do it beforehand. Afterwards, when the endo is finished, we remove the root. We make just a photo, so we take it out for a few seconds or so and put it back immediately afterwards. I will show you the sutures we are now doing for this. The main thing which we are using, what we are using in this technique, is that when we, for example, try to make orthodontic extrusion, we extrude it not downwards, we extrude it like forward a little bit. And afterwards, we have to, take out with burr all this dental tissue. We receive very short root, and sometimes this turbo extrusion takes like 2 steps and not so comfortable for a patient. So today we use also this technique when we have fracture line pelletly. We rotate it 180 degrees. That's how we can save the whole length of the root and also tooth structure. Usually it heals within 2 weeks. And here in 4 weeks, we just continue with build-up and temporary composite crown here. But sometimes you can use also direct restoration. It also feels okay. Here you can see post-encore and composite, milled and colored crown. So it's quite fast and aesthetic. In a year or so, it was quite stable, but then he was riding not a scooter but a bicycle. And now we can see that he's an uncomplicated crown fracture of 1-1 and a fracture of a crown. And thank God that everything inside was absolutely stable. So we just milled another crown from the same project. That was quite cool. You can see the new crown fixed. So we were quite happy with the strength of this construction. Let's take a look at another case where we used it for immature tooth. you see almost like longitudinal, like vertical fracture. We take it out. Here we used 90-degree rotation. We put the tooth back, positioning the fracture line just near the gingival margin. We prescribe only chlorhexidine and good oral hygiene. No antibiotics were here. Can you see these beautiful hemostasis? Because no blood supply was there. So we're just hoping for revascularization because the tooth is so immature that we really want it to grow. You see MTA plug here. In 4 months, we made simple, direct composite restoration. And you see the root obliteration in 1 year. Here's the workflow. You can see the X-rays in 1.5 years and in 3 years. Here he is, and here's our root. So yeah, we can make aesthetics afterwards more precise, maybe just replacing these composite restorations. Or he can make a crown when he grows up. Anyway, we're quite happy with the bone level and with gingival level. This guy hit the metal barrier while he was walking, and let's see what he has. He has one complicated crown fracture of 2-2 and complicated crown root fracture of 1-1. First of all, we are working a little bit with complicated crown root fracture, shallow pulpotomy and fragment reattachment, and splinting, just repositioning and splinting of the fragment of crown root fracture, so he can, so we can go through the consultation with parents. When everything is set, we start with operation. Here is not, the isolation is quite not possible or very demanding, so we are doing intentional replantation first and endodontic afterwards within 1 month. Here you can see that we took out the root. Definitely there were another treatment options. We could make root preservation and Maryland bridge, for example, but here we wanted to try to save this root for future restoration. Here's the photo after the operation. There are some sutures. I will show you a little bit later how our surgeon does it. And here's the final result after the operation. In 1 month, we made Boston core and endodontic treatment in 1 appointment. The tooth, the buildup is ready for temporary crown. And here also we had the composite colored milled restoration. How it looks like on the site. Although we lost some peaks, we have to think about it a little bit better. Maybe next time we'll make a combination of intentional replantation and orthodontic slow extrusion afterwards. We will check. But still, aesthetically, we have a really good volume here. And in 1 year, it's still stable. We have very good junction here. We're probing all the time, and we're checking the seal. We're checking gingiva not to show any symptoms of chronic inflammation, gingivitis or something. So this one is quite precise. Here we should stripe a little bit. Let's check how we do it. I will show you also this guy. He was hit by hockey puck. That's the situation locally. He started his treatment in a state clinic. So when they found out that there is another crack, they just sent them back, saying that nothing can be done here. So they just started endo there. Now you see video from the operation. That's what we did. We took out the smaller fragment, let's say. In this case, it was located vestibularly. So that's the fragment. Extends really below the alveolar crest. So afterwards, we extrude the rest up to the margin. We want to approximate gingiva to the periodontium quite tight. So we use this kind of suture. Our surgeon, Takhir, made this suture for this very situation. So just to tighten the gingiva to the root surface. That's because when we move apically, the tooth becomes thinner, and we want to epithelium junction heal as fast as possible without any bacterial load there. So when we position this root as we want to, so we can see the fracture line just near the gingival margin. We tighten this suture and we tighten up the gingiva around this thinner root. Afterwards, we splint it, of course. He's temporarily positioning the root so he doesn't have to fix it with hands. First, we attach wire to stable teeth, and only afterwards we reposition, we check the position of root again. We try to put it in the center, so we will not have to lose more hard tissue of the root. So we position it like just in the center. That's it. Usually we perform endodontic treatment and restoration within 1 month. From 2 weeks to 4 weeks, depending on the extrusion amount. So the more extrusion, the more time we have to wait. This time we wait for 1 month to build post and core and to fix the crown. You see some details after the operation, and here, and here how operation was finished. We made these recommendations usually, that's just enough. And here, in a month, post and core and temporary crown. We use BOPT preparation for the crown. It's like vertical preparation, not to lose more tooth structure. You see that we form gingiva, soft tissue. And here's the fixation of the crown. Please take a look at this beautiful new junction. Everything's on place. And here's the result after 1 year. Still, gingiva is sound. Everything looks very good. My heroes. Kirill is prosthodontic, and Tahir, he was also in ISDT conference. He's a surgeon, endodontic, and microsurgeon. So as to this technique, we really nailed this technique with intentional replantation with 180 degrees, post and core and the crown, or sometimes we make composite restorations. You have some advantages and disadvantages here. I would say that the main problem we had with this technique is when we didn't get the attachment right away. Usually it happened when a patient had something like periodontitis or gingivitis with poor oral hygiene initially, like this case. You see that all two fragments are like quite equal. So here we made this technique. Then we lost her for almost a month. Another dentist made restoration. You see, almost 1 month she had those sutures. And the restoration was not so slick. They had some problems, contamination perhaps here, maybe some composite or bonding agent. So it looks good, but still not biocompatible. So with a fracture line that extends too deep, or when we place restorative margin too close to the bone, we commit a biological white violation. And when that happens, the body doesn't just accept it, it reacts with inflammation, of course. So we have all these consequences of invasion here. We have persistent gingival inflammation, we have bone resorption and pocket formation. So we have really, really big problem. We have tooth mobility in such cases. So maybe if you have patients with poor oral hygiene, with periodontitis or something, we would prescribe systemic antibiotics at this time, and perhaps we will see a patient a little bit more frequently after the operation. For example, second day, just to check recommendation control and oral hygiene, and maybe in a week or 10 days. Here we stopped the inflammation with systemic antibiotics, but still we lost the peak, we lost the vertical bone volume, which is really not so good. I will show you, I have 5 more minutes, so I will show you some some cases which are I would say, как сказать, спорное. So, Ruslan. Ruslan, he came to us after falling down on the street. He's 8. He has root fracture here, and after splinting, the treatment of this tooth is finished. And here he has crown root fracture. Very interesting anatomy. Can you see? Here is the initial root fracture, clean, and crown root fracture here. First aid to just to approximate the fragments and to splint it rigidly so he can eat, and that would be just enough for this root. Afterwards, we had a long Zoom calling. Well, consulting a patient with a complicated crown root fracture can be quite time consuming. We have to talk about all these treatment strategies to tell the patient its advantages and disadvantages. And since these procedures are typically performed in 8-year-old child under general anesthesia, we need to establish an intraoperative decision-making protocol in advance. So we tell the patient's parents all these protocols, and we workflow as follow. If we can successfully stabilize the fragment and fix the fragment using surgical crown lengthening, we complete the treatment here. However, if the fracture line extends significantly below the alveolar crest, we will proceed with intentional replantation with 180-degree rotation. But if we find out that the root is completely broken, we will consider autotransplantation. So to be prepared, we always create surgical template for potential donor beforehand. That's why this consultation was quite long, but afterwards we couldn't reach those patients. They just gone. And in 2 months, when we finally when she finally took our call, she said that everything was done. We are asking, what was done? We went to our home city and there was a dentist who did everything. What everything? Can you show us pictures and films? And she said, yes, here you go. He did this. And we asked them to come to make new x-rays, and we asked, how do you feel? How Ruslan feels now? She said, not so good, because they are moving, those teeth are moving. So we saw him like this, and this time he already didn't have his milk canines to transplant here. They already were like resorbed. So we tried this intentional replantation of the apices. That's how the operation finished. Actually, when I saw those pictures, I felt like this. But in a month, we start to feel a little bit hope, but still not. In 3 months, little bit better, perhaps we will find some gravity. And in 4 months, we finally feel that we can continue. So in 5 months, we found, restorative, conservative desperado in our clinic who can make post and core of this apices. So here you see some restoration, just build up. And here we used temporary PMMA crowns, also milled, CAD/CAM. And as two teeth were very mobile, so they were moving like 3rd degree. we made this retainer, like orthodontic retainer. Here he is in 1 year. We're trying to correct his oral hygiene. And here he is in 2 years after surgery. They're becoming more stable, and his oral hygiene is a little bit better. 2 years in practice, still stable, little bit better with oral hygiene. So this technique really helps us in such profound situations. So the biggest challenge with intentional replantation is what we can call intraoperative surprise. We often discover occult fractures or additional microcracks that were radiographically, let's say, invisible. And often, if we see those additional cracks or additional root fracture, we are going to plan B, I mean autotransplantation. Because sometimes we find a really unrestorative status for these patients. I'll take maybe 5 more minutes, okay, just to show you that that's a typical case of school-age child that she was running and she slammed a door, and that's what we see. And this tooth on the X-ray is really unsalvageable. So when we took this out, we see that it's completely broken. So here at the 7-year age, we can consider deciduous canines for autotransplantation. I'll just go here quickly. This time, after this case, we perform endodontic treatment before autotransplantation. But here we did it afterwards, so we have this really big path. But still, in 1 year, in 3.5 years, he's still here, 4.5 years. And the main role of this deciduous canine is that we preserve the bone volume. We can also use for autotransplantation premolars. In these cases, she had a severe trauma in water park. I think I will skip the video, okay, of the operation. Yeah? You can show? Yes. Do you want me to show? So she has, let's see, we have to wake up, but because my slides are not moving, wake him up. He's sleeping. Yeah, thank you very much. That's the ankylosed tooth, which was with intrusive fixation. So you see 3D printed guides. The whole operation was made under general anesthesia. So we prepare the socket. This allows us to create perfect shape for the donor tooth, ensuring a passive fit without damaging any periodontium cells. And this is crown root fracture, almost no PDL, can you see? So there was chronic inflammation. Of course, such operations we plan with orthodontists, and here he gave us all these 2 premolars, upper premolars, and here's the final result. So we can use really different donors, and have you tried this one? That's our experiment on child. Let me show you what we did. And we are you saw this guy. He had this very big fragment reattached. This is the first state. and reattachment of the fragment with this problem inside. So at that time, 3 years ago, we didn't know that there will be a problem. We just made this restoration, we put this flap again, but luckily, I don't know, luckily, can I say luckily at this situation, because he had another trauma. He fell from a bicycle on the asphalt. And at that time when we saw him, we saw our restoration. Gingiva looks quite okay, but inside we have really big problem. We have big lesion here, we have very big bone loss here, vertical dimension, nothing. So now we see that still we're lucky. We have 2 donor teeth left. So we are planning to make this operation, I think, within 3 months, 3 or 6 months. What we're going to do, I will show you another case. So maybe Nitesh will see that we can do something with ankylosed teeth. Ankylosed teeth like this. We made subluxation and orthodontic extrusion. So we made it like this. We still preserved it. And in 6 years after total avulsion and replantation, it looks like this. What we could do for this patient? We found out that he has these donor teeth with immature roots. So here we made this crazy guy. You can subscribe. He makes this molar split and put this part of third molar here. In 1 month we made, and also, can you see, that's biodentin. So he left it vital. And we made this restoration just in composite. And you can see what happened. He's 8 here, replantation, ankylosis, our new root of third molar with MTA plug, revascularization. You see that new dentin is formed, and here it is in 1.5 months. So hopefully next time I'm going to tell about avulsion and ankylosis and 4 treatment strategies that we are doing with ankylosed teeth. That would be really, really nice. So to finish, some advantages and disadvantages of autotransplantation. I think that's not a secret. And as a final word, I want to say that all these things were made only for this, to preserve this bundle bone, which is not possible without vital periodontium. So not to go to this scenario where our children will suffer for 10 years or more without their frontal teeth, from this age of trauma to the point where they're eligible for dental implants. So preserving this amount of bone with all these techniques is the main point for us in here also. Of course, we're doing this only for this. I want to show you these portraits. I want you to look into their eyes, and perhaps you will agree with me that with their smile back, their eyes look more happy than without them. Also ankylosed tooth. Of course, none of this would be possible without my mentors and hard work of my team. So I want to thank my mentors. I still remember this moment where my way in dental traumatology started. I want to thank you, my team. I want to thank you all for your kind attention. Thank you so much.
It's been you first visited us in 2022 when we had Asian Regional Congress. It's been 4 years, and thank you so much that you agreed to come here and share your fabulous cases with us and your experience. And we are really honored to have you here. And
Thank you.
To deliver this operation. Thank you so much.
Thank you. Thank you very much, guys.
Olga, I was seeing faces of the people here. They were looking mesmerized, like we did some of the cases magical.
Thank you very much. All advanced techniques looks like magic. So
Thank you.
happy to share. Thank you. Wow.
To hold three things together.
Thank you so much. Thank you. Thank you very much. I'm so glad. Вот так. Thank you. Я покажу, что. Красиво. Еще что-то.